chapter program. I'm going to just pause just a second so we can find our seats. Thank you all. And we got very lucky through several emails to various people in Washington, D.C. Quite frankly, I don't remember the person, but somebody was very nice enough to refer us to a very knowledgeable person who has flown in for this event to be able to share with us a bipartisan perspective on some of the major issues going on in Washington, D.C., which we know are many. And the timing couldn't be better, given if you turn on the television at all or look at the internet, it's obvious that healthcare is top of mind. I think it's great to be in a field where it's top of mind. We always have somebody asking us their opinion, you know, or our opinion, I guess. Anyway, I would like to introduce Janet Marchibroda, who serves as chair of the Health IT for the Bipartisan Policy Center, a Washington, D.C. based think tank. And that think tank was founded by a group of bipartisan senators. The Bipartisan Policy Center recently released a report regarding the health IT capabilities needed for delivery system reforms. So here we have a very influential group looking at health IT and how it might impact the healthcare policies. Janet is also well known for her work as a founding CEO of the eHealth initiative. So she's going to be sharing this information, and I think I'm going to go ahead and have Janet come up, and we're very lucky to have her. Janet, welcome.
Thank you, Richard. It's a great pleasure to be here, and it's been so much fun to see so many old friends. It's been a while since we pushed for all that we got, and some say be careful what you ask for. With high tech and the investment of $30 billion into health IT, wow, so much has changed over the last several years. And so I'm really delighted to be here. There's a lot of exciting things happening in Southern California. So while you're eating lunch, let's see, let's check our time. Are we going to go till 1:45? At least, give or take. What I'd like to do is share with you some of the results of a report that we just released, a bipartisan report on health IT and how we're doing. And before I do that, if I could get a show of hands, how many people that are here are involved in whether a client of yours or in a provider organization getting ready for meaningful use? How many by show of hands? So that looks like, you know, about 60, 70% of you. How many of you within your institutions or a client of yours that you're working with are involved in setting up accountable care, or patient-centered medical home, or putting together connecting providers to deliver high-quality care? Show of hands. How many of you are doing both at the same time? So just a small set of you. I mean, if there's one thing that you'll walk away with today is, and the question that we asked at the Bipartisan Policy Center, we're putting about $30 billion of taxpayer money into health IT in this country. And by so doing, are we laying the foundation for delivery system and payment reforms of the future, coordinated, accountable, patient-centered care? And that's the question that we tackled, and I'd love to share some of the findings with you, have some conversation and discussion, and then talk about what that means for stage 2 meaningful use, and touch on as well, as Richard laid out, some of the conversations about healthcare reform in general. So let me figure out. As Richard said, who is the Bipartisan Policy Center? It was formed by all the former Senate Majority Leaders, all of them, actually on both sides of the aisle, not too long ago. And what they wanted to do with all the contention and all the dialogue and rhetoric that happens today is figure out, can we, in areas where there is disagreement, can we find some common ground through principled solutions around a range of topics? And we cover not just healthcare, but actually have our roots in energy and other aspects. Transportation, a lot of work on the deficit reduction, and economic policy. And so about a year ago, we launched our work on healthcare IT and have a terrific set of co-chairs of this health IT work. Senator Tom Daschle, he's a Democrat from South Dakota, former Senate Majority Leader, and Senator Bill Frist, a physician and a Republican who was a Senate Majority Leader from the state of Tennessee. And they have been taken on this challenge with a lot of energy, leadership, and enthusiasm, and it's been a great privilege to be working with them. What we did is we laid out the questions, and then we had a task force made up of a number of leaders from the employer community, Governor Engler, a former governor, but now head of the Business Roundtable, a number of health plan leaders, David, of course, our former national coordinator, physician leaders, those from industry and the like, and Jack this morning. So I got a sense of what Jack talked about this morning with his opening keynote. He was very instrumental in developing our recommendations. I'm going to, in the interest of time, I'm going to move pretty quickly. So we asked ourselves, let's not start with health IT, because as you all know, health IT is not an end unto itself, but we're putting a lot of money into it today. So we started out with, what do we need? If you look at the high-performing organizations in this country, and we interviewed 40 of them that were culled from research, that were actually delivering high-quality, cost-effective care, what made you successful? What were the attributes that drove your success in driving down costs and improving quality? And then we looked to see, well, how did health IT help? How did it get in the way? How could it have helped if it was there to help you? So what are the health IT capabilities needed? And then we crosswalked those health IT capabilities to where we are today as a country. And we found some pretty big gaps. And we've already talked about it in some of the panels. And I'm going to share some of those with you, and then came up with a set of findings and recommendations. So if you look across the board, there are some common things. And in the interest of time, we're at about 1:15. I'm going to go through each of them and talk about health IT, how it helps, and maybe isn't helping so much today in some cases and should, and then talk about some of our findings. The first was pretty much nearly every one of the 40 high-performing organizations, and they're in the back of our report. And I'll give you a link to it, but I just want to say that there are a range of large and small health systems, those within physician practices, as well as large integrated systems, the ones you always hear about, like Geisinger and Intermountain and the like, but also some patient-centered medical homes and state-run programs. What was the one common theme? Is that they've put the organization's focus on the patient. And that doesn't always happen, as you well know today. But that was a pretty common theme. And health IT can support patient engagement in a big way. But as we'll talk about later, there isn't very much of that happening in our country today. So organization-wide focus on the patient. The other thing is they all had strong organizational leadership, strong vision from top to bottom. They used data, right? Not just administrative claims data, but also clinical data, and from the high performers, data from the community that they serve. Because so much of what drives health and healthcare is really behaviors and things that fall outside of the healthcare system. I know we talked about that earlier, as well as patient information itself. So strong organizational leadership. And then getting clinicians involved in leadership was also a common attribute that you don't see across all healthcare organizations, but those that are high performing did that. And IT plays a strong role and could play a much stronger role, actually. We're going to talk about that. The other thing, common attribute of high performance, is they had access to information. There's access to information by clinicians from the multiple settings in which care and services are delivered. They wanted to do that, and we're going to talk about the gaps, but they struggled with it a little bit. And we all know, some of the gaps we have in the U.S. around health information exchange, and that many of them, but not all of them, and you're seeing this in a lot of the experiments that are occurring at CMS right now, as well as through private sector health plans, provide that access to information about patients by the whole team, not just the clinician, but the whole team that takes care of the patient. Timely access to care. And I know that this is something I had the pleasure of talking with the LA Care people about the exciting work that they're doing here. But the high performers provide more access to care, whether it's using electronic tools, same-day appointments and the like, and then virtual consultations. For some of them, not very many, and we'd love to see more of those e-consults happen across the country. Emphasis on prevention, wellness, and healthy behaviors. I know we talked about that earlier as well. High-performing organizations also do this, and I know we had some struggles in terms of funding for some of the prevention programs at the federal level, but this is a big area where there's great interest, as you well know, amongst employers and health plans across the country, and health IT could do a lot here, but again, we're going to talk about the gaps. And then finally, of course, accountability and alignment of incentives. All of those that were performing well, the incentives, the payment programs that were providing support for healthcare played a big role in that. And probably our task force said the biggest role. The biggest thing we could do as a country now is take some of those models around payment where we reward better outcomes as opposed to volume, and that could change a lot that we do in our healthcare system. So let's go. Before I go there, any other organizational attributes? As you look around you, did I miss anything? Other things where you see high performance locally or within your organization, ideas that you have that we might have missed? Okay, well, let's keep going then. So based on that, we looked at all of those things, and we talked about what's needed: access to information, access to data, secure messaging among physicians, and we saw that we have many gaps in our healthcare system, and I'm going to run through each of these. Of course, this was the biggest thing. Now, we are doing we're doing several. There's billions of dollars being spent by CMS right now on these pilot projects that will pilot different methods of paying for healthcare, whether it's bundled payments or shared savings, and that's one thing. If the Affordable Care Act goes away, we don't think that it will in total. It's not clear, no predictions. I know everybody's got their own views about it, but there's a lot of bipartisan support for the delivery system and payment reforms in ACA, and it would be a shame if that went away. So lots happening by the federal government, but a lot is happening actually in the private sector as well. A number of the large national plans and the regional and local plans are also doing quite a bit. You read a lot about it in the paper around testing accountable models of care. This is probably the most important thing that needs to happen in our country, is changing the way that we pay for health care. And we've got a range of ways to address that. So to align incentives, we'd love to see a long-term strategy for replacement of the SGR that's got components of accountable care in it. Not clear that we'll get there. We believe that funding and authorization of funding and funding of these pilot programs really needs to move forward. And if ACA does go away, that would be in jeopardy. And then the other thing is, with all this money moving into these pilot programs, particularly on the federal side, we'd love to hear more in real time about lessons learned. How many of you are involved in an accountable care effort today? You told me earlier. I mean, we're breaking new ground. It's pretty hard. And, even the best of the best are struggling with how to move this forward and how to use data along the way. Privacy and security. Well, we've all seen the reports of breaches, and we've looked at the research. I think gaining trust, solidifying public trust in health IT is going to be really important as we move forward. And we've got a range of recommendations in order to get there. The first is what the high performers told us and our task force told us, and just talking with a bunch of you during the breaks and the like, there isn't real clarity. If you talk to general counsel and various health organizations, folks are nervous about sharing information because understanding and getting clarity around the rules is a big issue. And so not necessarily new laws in all cases. There wasn't consensus there, but issuing comprehensive and clear guidance would be really important. We're going to spend a lot of our 2012 looking and providing recommendations for how HHS can make that happen. Big one. I think folks yelled the loudest on this one. What they told us, well, we moved to electronic health records, and we thought all of those folks that were handling the paper records, we'd be able to redeploy them and get some cost savings. Well, now they're in the basement dealing with the matches. The matching issue is huge. We heard that across the board. I think there's a lot of appetite for a national strategy for accurately matching patient data. I mean, how many folks in the room would agree with that? Yeah. Maybe not an MPI. Probably half of you think, oh yeah, heck, let's go to an MPI. We couldn't get consensus on that. We had a number of consumers, and I was telling Ray here before the talk, I've spent most of my time over the last 2 months on the Hill educating and raising awareness among folks on both sides of the aisle about this issue. And I think there's great interest in looking for a strategy that works for everyone, that builds trust with patients and consumers, but enables us to handle this in a way that reduces the number of mismatches and the errors that cause patient problems, that reduce cost and burden, and enables the lawyers to feel more comfortable with how things are moving. There is power in numbers in all of us coming to agreement on a national strategy, and that's another area that we're focused on very heavily at the Bipartisan Policy Center. We thought, what are those thorny issues that a bipartisan effort could help? And we think this is one of them. So accurately matching patient data. And this fourth one, David Blumenthal was a big contributor to this one. A lot of the breaches out there, a lot of the bad things that happen are just common sense. It's not some spy in another part of the world trying to hack your data. It's like stupid stuff, laptops, failing password protection. And, the sense was among the group, if there was, whether it's the federal government or maybe industry groups like HIMSS, coming up with some common sense, these are common security practices, and educating healthcare professionals and workers, boy, we'd get a much better outcome. Seems so simple, but there's a sense that we could be doing a lot more there. So we're hoping that will emerge from groups like this. On the adoption side, I won't spend much time there given our time. You've seen the meaningful use numbers. They're not going up as quickly as we thought they would. There are a whole host of reasons regarding why that is, but more needs to be done, in particular, helping the small physician practices. 74% of the care in our country that takes place in practices that takes place in doctors' offices are in practices that are 1 to 5 physicians. So that's most of where we all get our health care. And they're small mom and pops. A lot of times the physician's wife or husband will be, the receptionist, or they're just trying to make it. They're small businesses, and we need innovative strategies to get there. And a number of the regional extension centers have made headway there, but it's probably not the single solution that's going to get there. So we're hoping that more emerges, maybe not from the federal government, but maybe the health plans in the room, or the provider systems, or the health IT vendors that are out there helping folks move forward. So lots of work. We're not going to get there without your help, and so we're looking to innovation in that area. In the interest of time, I'm going to move more quickly. Big issue, and I know you talked about it, but if you look, and I know you just had a session on this, so this, of course, but if you look at accountable, coordinated, patient-centered care, so much of it has to do with clinicians or care teams engaging with patients, so much of it. And electronic tools and the internet and personal health records, whatever you call it, secure messaging, electronic tools could play a huge role here, but they don't. Hardly anyone's doing it, and we uncovered a number of barriers. You know, the physicians, many of them are nervous. They're nervous about which we found were unfounded, getting inundated by email, which again, when you look under the covers, you'll see that's an unfounded concern, some concern about privacy and security. But this isn't happening enough in our country, and that's a big area to focus on for all of you. How do we help? It's not forcing, and I think there's like, how do we together help the clinicians and the care teams in our country and the hospitals who are really struggling with those the electronic engagement with consumers? How do we help make that happen? And how do we help consumers want to use those tools? And we had a lot of discussion. The health plans have been early pioneers in this area. And we think a lot of it, there's some, and I know the California Healthcare Foundation has done a lot of research in this area. Some of it's about privacy and security. But I'll tell you, a lot of folks said it's just not, they're not usable right now. And so if we were able to download and get that information into those personal health records, maybe we'd have more uptake. That's a subject for an entire talk, I know. Okay, and then this is the big one. I really want to focus some time here. Okay, and this, for the people in the room, there are many of us that have been focused on this issue for a long time. You know what? This isn't happening. We are not seeing any level of exchange happening across unaffiliated organizations. Maybe some pockets in the country, you know, Santa Cruz and Indiana and Cincinnati. But for the most part, and when we talked with high-performing organizations and we said, are primary care physicians connecting with specialists or hospitals connecting with physicians? No, they're not. It's not happening in our country, and we are not going to get to coordinated, accountable care, patient-centered care unless that happens. Big conundrum. What are we going to do? And we looked at the federal policy. We identified some gaps and areas and have pushed pretty hard. Most of my time on the Hill and with media has been spent on this issue. We're going to spend a lot of energy and effort over the coming months on this issue. It's not uncomplicated. It's hard. We know it's a burden. We know there are policy barriers, but we have to get there, or shame on us on this $30 billion investment in taxpayer money without getting to interoperability and exchange across systems. So that was a big focus for us. Big issue is our incentives are completely misaligned. There's no business case for a physician. Let me restate that. Many physicians believe there isn't a business case for exchange right now because of the way we pay for health care. That's changing. There's some sense, and our national coordinator was involved in a lot of our meetings, so he's well aware, of our feedback on this. There's some sense that the path forward is not as clear as it could be, and I think that has a lot to do with first do no wrong. We don't really know the right strategy here, so we've got a portfolio strategy of state health information exchange grants and direct and NWIN, or I can never say the new way of saying it, NWHIN work. So there's a whole portfolio of methods. There are a lot of proprietary networks that are cropping up. Most of the investment in our country today is taking place in the private sector in support of accountable care. So there's a lot of things going on right now. We think there's an appetite, there's an opportunity now as we move to accountable care to come together on a path forward. Maybe not one method, but maybe a set of common principles and policies and strategies for getting there. And, we had almost all of the CEOs of the EHR, many of the EHR companies, and a number of health systems and doctors in a couple of months ago. And for the first time, I've been at Exchange for a long time, they said, you know what, I think we're ready. I think we have to do this. And, let's figure out which way we're going to do it, and let's move forward. And I was very excited. And so I feel that we have an opportunity to move this forward, but it'll take all of us coming to some agreement, because there isn't common agreement on a path forward. We think, I'm going to see whether there are any frowns in the room. We think that secure email push is a good thing and a good first step. Like the Direct project, we're really excited about all the traction that is being made there. But it's probably not going to be sufficient for coordinated, accountable, patient-centered care. We're going to need to get to, and I know Richard was telling me we've got a number of folks who are just learning about health IT, so what I'm saying is Greek to you, I'm sure. But there's a lot of policy dialogue around how we handle Exchange, and a lot of folks are just moving towards push of a simple email, maybe a PDF, maybe structured data. But if we're going to get to accountable care, we're going to need more than that. We're going to need folks not only to be able to push it, but also to query it. And that raises more complexities around policy, that the policies aren't as clear as we need them to be, and lawyers need to feel more comfortable. So there's some policy work here we think needs to happen in the next 6 months, the next 6 to 9 months, particularly in stage 2 if we move towards more robust Exchange, and if we want to get to lower cost, higher quality care in our country, this needs to happen. And so there's a lot of work around that. And then finally, this is more on the state and provider side. A lot of folks are feeling overwhelmed right now. There are tons and tons of federal programs. And the federal agencies are running as fast as they can. They've got to check a lot of boxes and get a lot of rules out the door. And all of us, all of you, are dealing with multiple programs that sometimes don't connect for you. Whether it's a health insurance exchange or health information exchange, or it's my Medicaid incentive program, or it's there are a whole host of things that need to happen, and, getting some alignment so we could come up with common solutions to slightly to multiple requirements will be important, and I'm not going to spend much time there. So, in summary, and I want to leave enough time for discussion, at 20,000 feet, what I'd love for you to take away from this talk is, if we're going to get to the healthcare system we need and we deserve in our country, which is coordinated, accountable, patient-centered care that will help healthcare be sustainable in this country and cost-effective, and one which delivers the best quality care that we can for the patient, we're going to need to solve a couple of problems. And we don't have tons of time, because there are some one-time investments here that will go away. And those two areas, probably the biggest areas we think we need to cover, are twofold. We need to get to bidirectional health information exchange. We need to figure out how we're going to do that as a country. And it's not something that the federal agencies can come up with and push down. We actually need to figure this out, because you are the ones that are in the trenches that know what works and what doesn't work, and physicians don't want to be inundated with all this data that they don't understand. There are all sorts of complexities here. That's number one. And number two, darn it, the rest of the way we operate in getting here and getting to Los Angeles, and the way we operate in our daily lives, we use the internet and electronic tools, but I'll tell you, we don't do that in healthcare. And so we need to figure out a way to make that happen. And I think a big part of that is helping our nation's clinicians and hospitals get comfortable, deal with the issues and the barriers associated with that, so we can find a way to bring that will enrich the experience for the patient and for consumers and all of healthcare. So those two big things are our most pressing recommendations. What does that mean in closing? Because I know, how many of you are responsible or interested or looking at stage 2 proposed rules? Wow, okay, so about a third of you. So for the students in the room, this is the big thing. These are the requirements that our nation's clinicians, they call them eligible professionals in hospitals, will need to achieve if they want to get an investment. The bigger issue there is they're worried about the penalties that are just around the corner. So there are a set of requirements that are out, and they have gotten more aggressive in some respects on those two fronts: health information exchange and consumers, engaging consumers using electronic tools. My sense, my prediction, is that there will be a lot of pushback. I think, again, going back to folks feeling overwhelmed, burden, cost, timing, feasibility, you name it, I've seen it all, I've heard it all. Okay, so with this end goal in mind, how can we tweak those proposed rules to make it work so we can still get to that end goal? And that's something I know, I'm going to be focused on, and a number of people are going to be focused on, and making sure that those are addressed in the proposed rules somehow, some way. And I know there's a lot of dialogue about whether the 10% unaffiliated makes sense and the like, but we need to get there. So those are the two big things in meaningful use, stage 2. And even if you agree with them, you still need to provide feedback that they're important. And then the second, in closing, Richard wanted me to talk about this. All the discussion about the upcoming decision in June of the Supreme Court about the Affordable Care Act. Nobody knows where they're going to end up, and I don't know how much of a policy discussion we'll have. But depending on how they end up, what are the implications for the health IT agenda? They're not huge implications. And I think particularly when we speak to a lot of doctors out there, particularly with the doctors, there's some nervousness that, I'm not going to purchase an electronic health record because the law will be overturned, or what if they overturn the law? And what's important to understand, particularly for the students in the room, is that the two aren't really connected very much. High tech, the $30 billion was authorized and appropriated under a different law that was passed, signed into law by the president in February 2009. And nearly all of that, the programmatic money, has been spent or obligated. There was a lot of movement quickly to make sure that happened. And getting access to the $27 billion, the dollars that are going out to doctors and hospitals, will be nearly impossible to do, even if you wanted to do. But they have nothing to do with the Affordable Care Act. So stay the course, move quickly so you can get in while the incentives are still there. It will be important. There are some things at the edges, and I know I'm looking at the clock. I'm going to try to, so without spending too much time, as you've looked or watched the news and the like, there are a number of scenarios that could take place in June when the Supreme Court rules. I'm going to try to do this quickly. They could throw out the mandate and the insurance reform. I don't know how to do this. There are a number of scenarios, but let me just say in summary, most of the scenarios will have little or no impact on health IT. All of the likely scenarios will have no impact on health IT. In a worst case scenario, a negative impact would be if they strike down the law altogether. So they could strike down the mandate, strike down the health insurance reforms, they could strike down the mandate but not the insurance reforms, they could keep it all intact, or they could get rid of all of it. Number 4, getting rid of all of that could have impact on health IT in an indirect way. And I'll say this briefly because I know we're looking at time, but remember I talked to you about some of the pilots that are taking place and how alignment of incentives drives everything. And there's about $10 billion being spent by CMS fairly quickly on piloting different models for paying for better care, not just paying for more care. That's really important. And actually, the biggest driver for health IT and health information exchange is actually paying for better care. Because what health IT reveals, when well implemented, and all the caveats, because I know there's been a lot of articles about this lately, it reveals when you're going to duplicate tests, right? Tests that have already been done, so anyhow, long story short, if that gets kicked out, that's going to be yucky. Not good for health IT because we really need the alignment of incentives to happen. But other than that, we don't see a lot of impact of the Supreme Court's decision. So stay the course, keep moving. This is hard as heck. And share, 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 because everybody across every community in this country is struggling with this. And if we can find a way to quickly, rapidly iterate and share our lessons learned, that'll help us all. So, 1:45, thank you.
Time for
quick overview. I'm here. If you go to www.bipartisanpolicy.org, you can get an electronic copy of the report. We intentionally, you're going to love it. I mean, you could give it to your mother. You could give it to your doctor. You could give it to anyone because it's not a wonky health IT report. We intentionally described what's needed for higher quality, better care, and why health IT matters and what we need to do in very easy to understand language. We did that for a reason. We felt like sometimes we were all talking to each other and not talking to the folks that really make decisions in this country. And so it's a nice, easy read. You could read it in 20 minutes. So thank you.
Do we have time for some questions from the audience before? We've got a couple of minutes. I have one, and I promise it's a bipartisan question.
I was telling Richard I couldn't say very much about this.
No, it's okay. But for those of us who are disciples, which I'm sure is everybody in this room about health IT, can you give us any sense of what the persuasions or the thinking is about health IT as a fundable governmental program on the congressional side? Can you
Sure.
Can you just give us a sense so that when June comes around, we'll have a sense of how Congress thinks about health IT as a top of mind? Do they think it's better than all the other programs that are out there? Any kind of sense that you can share?
So, as I mentioned earlier in the talk, I've spent most of my time over the last couple of months raising awareness of our findings, not only with the administration, actually the administration officials, we kept them apprised all along the way, and they observed some of our meetings and the like. But members of Congress on both sides of the aisle, all the major committees in the House and the Senate, on our report. And I think there's still very strong bipartisan support for high tech and for health IT. I think where there are some concerns, and they relate to, but not big enough concerns to impact funding, is goodness gracious, this is an enormous amount of taxpayer dollars being invested. And weren't standards and interoperability, we never intended to invest in silos in our country. And that is indeed what's happening today. So I think there's some frustration about the lack of health information exchange, particularly because that is going to be needed to drive improvements in quality and reductions in cost, because this was supposed to improve costs. So I'm hearing some concerns actually on both sides of the aisle on the Hill around the lack of forward, strong, bold movement on bidirectional health information exchange, preferably actionable data that can support coordination and accountability. But they can't pull back any of the programs if you're involved in RECs or State Health Information Exchange, or it will be nearly impossible to pull back the incentive dollars, so that won't happen. You might see a few more oversight hearings. We saw those last year. Particularly as things heat up here with the election, you'll see more. But again, if you look at the Republican candidates, they've all been strong supporters of health IT. Privacy, I don't think it will rear its head in this. I think we need to tread carefully on the conversations about accurate patient matching. I think that's going to be important.
So
Yes,
can you
ma'am. Hi.
say a little more about the business case that you would present to a doctor who's got computers, the case for HIE? You mentioned that as one of your bullets there.
So one of the biggest drivers for a doctor, and I didn't talk about the scope of our work in the coming months. Next month, we're going to be fielding a very large-scale, comprehensive survey on what clinicians need and want from health information exchange at a very granular level to help drive the right policy in this regard and the right practice. And I think they're going to tell us a lot of things. I think we're going to sit up and listen and figure out, how are we going to move forward. But I think clinicians
I think you might know that already. So what do you think they're going to answer?
I think that policies and strategies around exchange need to be driven by those who are working with the data at the point of care. And I suspect, although I don't know, is the presentation of the data, the types of data, the points in time, whether this is a one-time visit with a patient versus a diabetic patient that I'm managing over time, the information needs are going to be different. And I think there's a huge business case for clinicians who want to deliver better care. At the same time, particularly primary care physicians who are being paid on volume as opposed to outcomes right now, that's a tough sell. And I think as these new models of care moving forward, and they are moving, private, it's not just the government. WellPoint, United, a number of the Blues plans are implementing new models of care. That will be the biggest driver. And so I would focus on that and look forward to working with you all on the business cases. Thank you for that question. Okay.
At this point, we have another little event. Anyway, Jan,
Okay, great.
Thank you,
Richard. Pleasure. Thank you.
And now I think we have some sort of a raffle, so I'll let